All right, so I'm going to show you. This is a SOAPy card. Now, none of this is required of you. You may take it as you wish. I put it up. I just added it this morning under your modules, this little SOAPy card. It's a template. I am asking Block 3 and Block 4 to prep with these and to study with these, okay? Because everyone asks, what's on the test? What's on the test? And you're getting into a whole bunch of problem-based stuff. Now, I mean, your lectures in Med-Surg are, what lecture have you had in Med-Surg? Is this your first one? What was your first lecture? Diabetes. Okay, diabetes is a perfect example of a problem. Okay, this is a problem that people have. It's not the only problem people have, but it's one of the problems people have. So what I would recommend you do, and if you don't do it, it's up to you, is create a SOAPy card for each diagnosis, each problem that you're learning about. And in Block 3 and 4, I list all the problems we're going to be learning about and say, make a SOAPy card for these. And then what you're going to find out is as your patients get sicker and you have these, you can take them to clinical, and you have all your stuff with you. And then as you end up with these sicker patients later on in Block 4, you may be pulling 4 or 5 SOAPy cards for your patients, okay? My patient's got CHF. My patient's got diabetes. My patient's got renal failure. My patient's got... So you pull all the SOAPy cards and see what's connected. What's in all these things? What are my priority? Which one's prioritized? So we'll be able to work with these and come up with good care plans and things to do for your patient. Because if you just learn about everything in a little box and then put the box aside, you're never going to be able to manage an entire patient that gets complex. And no patient just comes to you with, I just have diabetes, maybe a 7-year-old kid or whatever. I just have diabetes and that's my only problem. But that's the way we're teaching you. It's like, here's a problem, here's a problem, here's a problem, here's a problem, and they're all in their little boxes. And you think, I'm going to learn this box and then I'm going to put it aside. Well, but patients don't have little boxes. They have mountains of boxes. So what we're going to do, and you'll see how we use these. So you can do this now. You cannot do this now. It doesn't bother me, even if you don't do it in Block 3 and Block 4. But I'm introducing it to you now so that you can use them. You can use them on your other lectures as well, and it will help you kind of put things together. But what this is first is what will your patient tell you and what will you see on assessment. So recognize the problem. So if we do a SOAPy card, and I'll do one on the board as we go through the PowerPoint so you can see what I'm talking about, how we're going to use it. But what will you see if you have this problem? So when we talk about rheumatoid arthritis, what will your patient have with rheumatoid arthritis? You did diabetes. What signs and symptoms are you going to have with diabetes? So you would write in all your signs and symptoms. You can go through your book, you can go through your lecture, you can go through the internet, wherever you want, and kind of put it all in one place. Now, this SOAPy card may not be one page. You may find out, I'm going to trash some of this stuff or whatever. What are your primary problems? Because if you look at test questions, we're going to give you, your patient comes in with this. You're going to have to recognize a problem. This sounds like diabetes because I remember my signs and symptoms. So the first box is kind of putting in signs and symptoms, okay, in your subjective objective part. Now, you can do these patient-based, but we're not worrying about that at this point. This is just for the disease or for the diagnosis or for the problem. What will your patient, and so some patients will tell you something, some patients won't. But what are some general signs and symptoms of this problem? What is the underlying cause or pathology? You don't need to write a book. But for rheumatoid arthritis, the underlying cause is autoimmune disease. Okay? It can just be a very quick thing. You don't have to put a whole thing. Autoimmune disease, result of an infection, whatever the problem is, and we'll do them with each one. But what's the underlying cause? You can kind of think, because as soon as you hear autoimmune disease, your mind will start clicking. What's the treatment for all of the autoimmune diseases? Are going to be steroids. So it will start to click after a while, you'll see. So underlying cause. Is this a problem priority? Does it involve airway, breathing, circulation? If any piece of this disease process or whatever you're learning about, like diabetes, does it affect airway, breathing, circulation? Circulation long term. Will it be one of your big priorities, like ABCs? Probably not. It's probably not going to be your biggest priority. So when you have a patient with CHF, diabetes, renal failure, You can organize your little cards into your priorities. Your top priority, your diabetes goes to the bottom of the list because it's not a priority problem. So you'll see when you get more complex patients, you'll be able to organize them in your priorities. So you can always put, is this problem a priority? You could say long-term circulation effects, no other effects on airway or breathing, usually diabetes, just because you've already kind of gone over that. What is your priority nursing diets for this condition? This one, this plan and priorities section, this one doesn't always, you're not going to always put nursing diagnoses, but if you had a screen that said nursing diagnoses would go with this illness, you could put those in there. The reason is we need to kind of decide what interventions we're going to do. What are we going to do? This one is stuff like, and what I like people to focus on is what's the worst thing that's going to happen as a result of this problem? So with diabetes, what's the worst thing that can happen to you if you don't treat it? So yeah, you can put in what's the worst possible, most likely complications to anticipate. DKA. So you don't treat it. What can happen? Your sugar will go through the roof, right? So the worst things that can happen around diabetes is your sugar's out of control. Hyperglycemia, hypoglycemia. Okay? So right here in your planned priorities, your priorities are going to be keeping the worst thing from happening. Okay? First, yeah, we know we have to treat it. We have to take care of it. But what are we trying to ward off? If we don't treat it, what's going to happen? If hypoglycemia, hyperglycemia. Make it simple on yourself. So the worst possible complication for diabetes will be hypo and hyperglycemia. You don't need to write more. You could go grab your SOPI card for hyper or hypoglycemia. But those are the worst possible things. So what nursing assessments will help you identify hypo or hyperglycemia? What assessments would you do to see if they are becoming high blood sugar or low blood sugar? A glucose check. Dude, we're creating interventions for diabetes. You better make sure, because the worst possible scenario is that they get high blood sugar or low blood sugar. So you better be doing your glucose checks. Ding, ding, ding. So you don't need to write that in this, but you can write glucose checks. You don't have to write a whole lot of stuff. This is stuff that's going to help you later on. And you can take these SOPI cards. That's why I gave them to you as a template. You can make them on your computer. You can not. You can do whatever you want to do with them. And you may end up adapting them as you go through the blocks. You're like, you know what? I've never seen a patient happen to this. We've never talked about this. I'm going to rip it out. It's not necessary. But glucose always comes up with diabetes. I better make sure that's in my thing. What are your goals for this problem? Probably to maintain their glucose at a normal level, right? That's all you need to do. And then you've made a care plan. You have a note for anybody with diabetes. You better be doing their glucose. I don't care how good or how bad or how under control it is. You want to make sure that their glucose stays within their normal range. And you better be doing blood glucoses. First intervention. That will be your priority intervention for this patient, is making sure they stay stable. Because that's the biggest thing. We don't want them going to their worst case scenario. So that's kind of, along the line of plan and priorities. And then implementation. There are 5 different kinds of interventions that we do. Nursing interventions. You get those little slides that say nursing interventions. There are 5 different kinds. One is monitor assess. We want to make sure that things aren't going to happen. So you can kind of put things down in that monitor assess thing. What is important? So what data needs to be trended because it can detect a change in status with diabetes? What do you need to watch? Your blood sugars. Hey, that's coming up twice. That's pretty important. So your blood sugars. What else would you trend on a patient because it can detect a change in status? Maybe someone who's more long-term. Mental status. Very good. If they get hypoglycemic, their mental status will change. Their mental status, you'd write on there. What other things would change? Their hemoglobin A1C is a very big indicator of whether they're maintaining long-term. So you can write A1C long-term. So you can see that, hey, when your patient comes in with a diagnosis of diabetes, you better be monitoring the blood sugar, and you better check your chart for hemoglobin A1C, because then I'll give you an idea of how well they're doing. Check the chart, see if blood glucose has been done. Maybe you're going to go in and make sure that you do a mental status assessment on this patient to see if they are hypo or hypoglycemic. You're already creating a care plan. And so what we're going to do is we're going to do this over and over and over again until it's second nature by the end of block 4 for you to be creating care plans in your heads for these patients. Because when you meet a patient with diabetes and renal failure, I want you to already have your file cabinets in your head opening up and you're pulling out this parts and you're like, I'm checking my chart for my renal labs, my glucose, my, you have an idea in your head of the things that are important to look at. And that's what we're going to do over and over and over again until the end of the course. Yeah.
So you just started this semester?
The SOAPy notes?
Yeah.
Yeah, we did, because what I was finding is that people weren't studying the right things for the tests. This is all we're testing. Can you identify a problem and intervene appropriately? So we put these together. I mean, this SOAPy note's been around since 1980s. I mean, I studied SOAPy notes in college. So SOAPy notes have been around for a long time, but they were patient-based. Here's what my patient is telling me right now, but it doesn't. So I was like, well, why don't we just do this for every problem that we give you? And then you've studied. If you put together these SOAPy cards, you've studied what you need to know. There's no question about what you need to know. And I was telling people when we were tutoring, they're like, what do I need to know? I'm like, well, you got to be able to recognize a problem, and then you have to decide what's appropriate to do about that problem, because the questions are going to ask you, what's your priority intervention? What's the next thing to do? What do you want to do next? Well, this will help you study for that.
To elaborate, I respect a lot of the reading. Like that, the initial stuff you read, like especially on immune, is very dense material.
Mm-hmm.
There seems to be a lot of review. Is that kind of what you're asking?
Right.
So you're asking us
Do
to
you
review?
see how important pathophysiology is in this thing? Not very.
No. So.
That's what I'm not going to study. I'm not going to test you on pathophysiology.
Okay.
This is not a pathophysiology class. I will test you on pathophysiology as it relates. You might need to know that, because then you'll know what meds to pick.
Okay.
So, but if you do these cards, you will summarize it for yourself. Yes, there is a lot of review, because the more you know about the background of a disease, the more you can just guess what the proper interventions are going to be. But if you like to memorize things, then I would say put that information into a format that you can use. So this is, what assessments do you need to do? What interventions? This is what usually you're trying to learn to memorize. What meds go with this condition? What treatments? This is, surgical interventions, medical interventions, medicines we're going to give for that. So diabetes could get pretty extensive. So what I would do, and we're going to kind of talk about, so when you start getting that there's a lot of medications for that treatment, you can see diabetic medicines, make a different card for all your diabetic medicines. So, do you want to write all your medicines on a SOAPy card? That's up to you. You can put it on the back. You could put it on another page. But that's where you start getting classes of medicine. So when we talk about blood pressure, you can't write every blood pressure med on that. But the interventions are antihypertensives. And then you can go, there's like 50 billion that you can pick from. So now you're going to start having drug card, So it's going to create what I would think, and what I would have liked having gone into this, is a quick reference. And you could buy these quick references if you find a book that works for you. You don't have to use a SOAPy card. But I developed this just as an idea for what is important, because that was the question I was asked over and over and over from every single block. When people would come, they're like, what do I need to know? I'm like, this. So I'm going to present it to you at the beginning of block 2 and say, this is what we're going to be doing, because this is what we do. And this part right here is what makes us different from LPN, practical nurse. This is what differentiates us, right? How many people here are LPN or practical nurse? Or what do you do all day? You do this, right? You do this. Do you do this? Do you monitor assess as an LPN? Not to put you on the spot. So you're in this part right here, perform and care. So we are expanding you from perform and care to giving the medications, to doing the interventions, doing the ADLs, doing the things. Those are all perform and care. That's a big chunk of what we do. But it's the rest of the chunk of what we do that separates us out. That's what you're doing as an RN. You are figuring out what to monitor, assess to keep the change in status from happening. You are teaching and instructing. You are managing and referring. And LPNs are 2 and 5. Okay? They are performing, intervening, following orders, doing what needs to be done, and caring for the patient. But we have extra, and that's what you're coming to school to learn. So if you're not going to do the monitor, assess, the teach and instruct, the manage and refer, then be an LPN. I mean, because that's what they're doing, is performing and caring. That's part of nursing, but it's not the whole part of the RN. So we're just basically, we're expanding you. And if you have not had any background and you haven't had a chance to be an LPN, then you're learning all 5 pieces of this. But that's what we're kind of doing. So, I have people tell me, just tell me what to do and I will do it. I'm like, well, if that's what you want to do, if you want me to give you a set of orders and you follow them, regardless of what's going on, and you just, this is what I'm going to do, I'm going to do a checklist and do that, then that's great, but you're not an RN. Okay? The RN does have to monitor, assess, does have to teach and instruct, and does have to manage and refer. Okay? So that's why we're gonna bolster that piece up with it. If you're coming in with some medical knowledge, if you've been a CNA or a PCT, you're in this level as well. You're caring for patients and you're in this, I've been told to do this, I'm going to do this. But is it appropriate? Is it proper? Is it right? Is it the best thing? That's RN. So that's kind of how we can differentiate. And that's what I want you guys to pick out. So if you've had the luck and the joy of being in the medical field already, if you've been a tech, you've done pieces of probably 2 and 5, and maybe you've dabbled in a little bit of the other ones if someone's told you, go do it. But here we are learning how to do all of it. And then if you go on to be an NP, I know some people want to be nurse practitioners, and some people want to be nurse anesthetists, and some people want to go on to higher level nursing. Well, you need to be really comfortable with all this, because you do it at a higher level, you take more responsibility for it as an NP, but you're doing all of this. So, okay, we're good there. So as you go through the slides, we will put them in the implementation section and try to decide which one it is. And then the last piece that we missed, and that's why I really started this, was what does it look like if things get better? How do we know that what we did worked? And that's the last piece that nobody really likes. It's boring. The follow-up. Yeah, we did all the right stuff, but was it the right thing? Sometimes we treat people for their diabetes, but it's messing up their kidneys. Or we treat people for the kidneys and mess it. So is what we're doing working? The evaluation piece. So you will hear me talk about these as we go through the thing. So I'm going to put it up. And the limitation for this, what you're going to hear on YouTube when you re-listen to this lecture, is this just records what's on the screen up here. All it's recording is what's coming out of the projector. It's recording the computer screen. You can hear my voice, you can hear the class interaction, but you won't see stuff that I put on the whiteboard unless I whiteboard it on the iPad. So I'm still getting used to that. I love the whiteboard, but there's no way to record the whiteboard at this point. So you might want to, maybe take notes if I start going to the whiteboard, because that's where you won't see that in the lecture again.
Miss Diana, what is your YouTube channel?
I will send it to you in an announcement.
Okay.
Don't worry, you'll get it. You'll have to find it. No. All right, so let me grab this, and I'm just going to put these to remind me what we're going to be doing. So we'll be filling these in. So yes. And then what are these over here? The 5 of them. I just want to remind myself until I get it memorized. Okay. So now they're like, finally, you're going to get to it, right? Oh, thank you. If you missed the sign-in, it's going to stay up here. You can get it on a break. So, with that being said, we're going to go into the immune system. This is what I want you to do. I'm going to probably start putting on these pages, I haven't gotten it yet, the it's on the first page of the things. If there's any disease processes, I need you to know for the section. This part right here is background. So I'm going to tell you this part right here is background. You will need to kind of be aware of it, but whether there's test questions on it or not, it'll probably be, there'll be interventional based on stuff that we're learning about in a little bit. But we know that there are bacteria, viruses, and those are the three things you can get infected with: bacteria, viruses, fungi, things from the outside that get into us and get infected. And those are called pathogens. So a lot of this is vocabulary. I just want to make sure that we're all on the same page with vocabulary. The healthcare associated infection, you've probably heard about these. This is also vocabulary. Healthcare associated infection, HAI. They will be called CODI, CLABSI, SSI. You'll hear all kinds of nice little, we love our abbreviations in medicine. So these are basically infections that you wouldn't get if you were just out wandering around in the world. They're because of something that happens in the hospital. So that's what those are. That's just kind of vocabulary. I figure sometimes I'll say these things and people look at me with a blank stare and I'm like, nobody told you what that meant? Okay. So that's what they meant. If you hear CODI, it's a catheter-associated one, meaning urinary catheter. If it's a CLABSI, it's a central line-associated bloodstream infection. And I'm not going to test you on these vocabulary, but sometimes it's just like I say stuff and you're like, what? I'm like, well, we never told you that word, huh? Okay. Well, there are some of those. So just read that over. I'm going to put this up. This is a link to a background video. I love Crash Course. They're very fun. They're entertaining to watch. It gives you a little background of how the immune system works, but I'm not testing you on it, so I'm not going to spend a lot of time on it. Again, it's background information. We are going to go over what is inflammation. It's important. You've probably heard about it when you did wound care and all this stuff, but what is it? What happens when you get inflamed? What does that mean to you? You've had an injury. What happens when you hear the word inflammation? What do you think? Swelling. What else? Redness, swelling, pain, heat. Perfect. That is the inflammatory process. You've already got it. Here's why you have all these things. Basically, when you get an injury, the word histamine and complement. Hey, wait, I've heard histamine. Where have you heard histamine? An antihistamine. Oh, we've created a med to block a histamine. Why? What does histamine do? It starts the inflammatory response. Histamine is just something that is released from an injury site and calls this inflammatory response. The inflammatory response is our first line of defense, and it includes heat, swelling, pain, redness, and that is because this histamine tells the capillaries to open up. So we're going to use a cut on our finger. We're going to cut our finger. What's going to happen right there? Well, it's going to bleed. We're not worried about our blood system at this point. But it is going to bleed. It's going to start swelling, and it's going to bleed, and it's going to get kind of swollen. Because around that incision, all the capillaries have gotten leaky. So yes, it's letting blood out, but it is also letting white blood cells to the spot, platelets to the spot. It's letting everything out of the bloodstream to that tissue that's been injured. So everything starts pouring out of the blood cells to that site to take care of it. It's basically an open construction zone now. And they've opened the gates and the capillaries are loose, and now all these cells that are normally maintained in our bloodstream are now leaking out around that area to do whatever they need to do. Exudate is, what does that mean? It's just discharge. Yeah, it's just like, it's not active bleeding, but it's all I haven't finished my coffee yet, so I'm losing the word. But just all that clear drainage that's coming out around there. It's fluid, it's leukocytes, it's white blood cells, it's all the stuff that comes out. It's just the swelling. So exudative swelling, and then localized heat is also that around that area, everything's happening, okay? It's busy there. There's a lot of metabolism. Healing happens better in a warm environment than in a cold environment, so it ramps up the heat. Vasodilation around there, there's more blood cells, there's stuff going on, it gets heat. So red, hot, swollen, you know what inflammation is, that's just kind of the background of what's going on behind it. And here's another picture of what's going on behind it, but all you really need to know, you don't need to know all the fancy words. Heat, redness, swelling, tenderness, pain. You already got that. You passed the first question, you know what inflammation is. So hopefully, the inflammation process there kills off any bacteria that got in from the cut. And you don't need to go any further. All these white blood cells that showed up during this process killed off any bacteria that happened to get in, and then they healed it up and it's over. Okay? The first line of defense is all you need. But sometimes you need more. And we'll talk about that in a minute. So we have acute inflammation, subacute inflammation, chronic inflammation. That is all inflammation. It's all leaky vessels. It's all redness, swelling, heat. But those are just vocabulary words. So if that first defense, that local inflammation, is not enough to kill whatever got in there, so say you hit a rusty nail, not just, maybe, or a cat scratch or whatever it was, and those bacteria there was so much bacteria that got into that thing that the little white blood cells that escaped couldn't deal with all that bacteria. Then you start dealing, those bacteria hey, those vessels are leaky. Those bacteria could get in. So they start kind of circulating around, or those bacteria are just like growing right there on that area, and the body says, I need more. I've got to get more help. Then it sends signals up to the brain and creates a systemic inflammation. So basically now we've got the whole body involved in sending out processes. And that gives us our secondary immune response, which is where we start getting these white blood cells more involved. You get specialized white blood cells sent to the front, okay? If you watch that little video, it's so cute. He makes it like a little war movie and all these little white blood cells are coming. Very fun. These are the most common words that you will hear from the immune response, okay? Antigen just means it's an invading bacteria that's been cut up. So I think he uses in the little video slide, he talks about how this is like the spoil of war. Like one of the white blood cells will grab it, eat it up, and then put it on its flag and raise its head up and say, look what I killed. But what it's doing is it's saying, hey, anybody out here recognize this thing? So let's say it's a bacteria. Let's say it's E. coli. E. coli lives kind of all over our body. So this bacteria, E. coli, gets into this cat scratch wound, or the cat had E. coli all over its claw, and when it scratched you, the E. coli got in here. So those white blood cells at the local site are trying to kill off that E. coli bacteria, and they're presenting this little head of the E. coli. Like, look what I killed. Does anybody recognize it? And as the blood courses around, some white blood cells will be like, I saw that before. I know exactly how to kill that. And they come out and they go to town on that certain bacteria because they recognize it. So antigen is a piece of bacteria or something that triggers an immune response. These activated T helper cells are basically the ones that are going around waving flags going, does anybody recognize this? Is anybody recognizing this? And asking for other white blood cells to come to the scene. I don't think we haven't really used complement system. Don't worry too much about that. Prostaglandins are other things that will help increase blood flow to the area and cause swelling. They're just more things that will get help to the area. This is also what causes your pain at the area is prostaglandins. So if you ever wonder how Motrin works, it works down here by blocking prostaglandins. So it stops the pain and it stops that prostaglandin calling more things to the area, so it stops the inflammation. But Motrin works in here with these prostaglandins. So anyway, it's just kind of interesting when you start looking at medicines. And again, this is me in biochemistry. I love the body. I love how everything works together. But so here, if you wanted to make a Soapy card for inflammation, which, okay, let's make a Soapy card for inflammation. It's really easy. What would we see for inflammation? Hey, all of these things. You can put these things all under inflammation. Redness, heat, tenderness, swelling. Yeah, you're going to see that. If it goes beyond, which inflammation is inflammation. Redness, heat, swelling. That's pretty much it for your Soapy card. That's all you're going to do. Let the body take care of it. When we need to start getting involved is when it starts to become systemic. When the body's asking for more help, we start seeing more symptoms, okay? We may or may not need to get involved, yes, so we have the next thing. So we have an increased white blood cell count. We have tired, because now you've got a big thing going on and they're trying to conserve energy. You get nausea and anorexia because the body's like, dude, I don't have time for digestion, okay? That requires a lot of work. I'm over here working. I don't have time for that. So it kind of sends out signals like, don't eat right now. I can't handle food. Increased pulse and respiratory rate. We're trying to get more stuff to the surface. And the fever comes because we're trying to ramp up the body to kill the bacteria. Okay? We only live in a certain range of temperature, right? So do bacteria. So our body will up the temperature to actually kill bacteria. So the purpose of the fever is to kill bacteria. There is no other purpose for the fever except to ramp up our metabolism and kill bacteria. So you're thinking, why do we stop fevers? Why do we stop fevers? Why do we treat fevers?
Well, if the temperature gets too high, it could be bad.
Correct. If the temperature gets too high, we only live in a certain temperature range. 96 to like 102, I guess, 103. Anything above 102 starts to damage tissue. Yeah, it's killing bacteria, but it's damaging our tissues as well. So if it goes on too long, it could cause problems to us. We live in that little range. So long fevers that last a long time at very high temperatures can hurt us as well as the bacteria. But fevers themselves that are not too high to damage us, let it go, because that's its purpose, is to increase our metabolism and to kill bacteria. The other thing we do, why we treat fevers, is because the signs of a fever are annoying. And we don't like them. And so we want to tamp it down. But when we tamp down the fever, we are also not letting it do what it needs to do. But the signs of a fever are a high body temperature, increased ventilation. Why do we have higher respiratory rate? You've got to get rid of waste. You're trying to get more oxygen to that site. There's healing going on. There's a construction site that needs equipment, and the equipment is oxygen. It needs oxygen to do all this work. So we're trying to get more oxygen to the site, so our respiratory rate goes up, plus we're trying to get rid of all this extra junk that we've made from the construction site. Increased heart rate. Why do we have an increased heart rate?
Get more blood circulation.
We're just trying to circulate stuff around. Unstable blood pressure. Because we've got a lot of stuff going on. This is systemic now. We've called from there's stuff that has left this wound, gone up to the brain and said, we need a fever, okay? We need a fever. There are bacteria running out of control. We can't manage this population down here. There are bad things happening. We need help from the rest of you. So the brain's like, sure, let's do it. Let's make a fever. How do you make a fever? The signs and symptoms of a fever are you making a fever. We have to create that temperature. It doesn't just magically appear because the brain says, be hotter, and then you're magically hotter. We have to make it. And that's why when you're spiking a fever or getting a fever when you get the flu, you have these signs and symptoms. You are making your body temperature go up and down to keep it in a certain range. Okay? So the brain says, all right, fine, we need more help. We got bacteria running all over the place. We're going to cook them. So let's go. Let's go to town. Let's start cooking. So the brain starts sending out messages that says, how do you cook? How do you retain warmth? How do you start creating cooking? How do we start cooking? How do we raise our temperature? Well, you could go exercise, but we're not going to do that. They do it by vasoconstriction. If we clamp blood vessels down, then heat can't escape out of them. Okay? So we're going to clamp things down. We are going to vasoconstrict. Hey, guess what happens when you vasoconstrict? You look pale. So we are going to, so the brain sends out a signal to all the blood vessels. Clamp down. We're going to cook mode. Clamp down. So you start getting pale because you're clamping down. You are going to shiver. Hey, all that muscle energy creates heat. So we are going to clamp down and you're going to shiver. What are goosebumps for? To retain heat. It's an old, if we had fur, it would make our fur stand up and bunch together, and it would retain heat. So we are doing these things to retain heat. We're trying to get from 98 to 101. So we have to do these things to kind of get going. Most of the time, just clamping down is enough to get our temperature up. So when you start feeling sick, you get pale and shivery, your fever is going up. So the brain is a wonderful thing, and you start to get up to about 101, and it's like, all right, shut that down. We're going too high. Stop it. So what happens? How do we release the warmth? We're going too high. We don't want to overshoot. How do we stop that process? Open the blood vessels, vasodilate, let some of it out. We're going too high. Release it. So we vasodilate, which gives us flushed skin and sweating. That's how we release heat. So to maintain a higher temperature of 100, 101, we need to get cold. We need to clamp down, but we don't want to clamp down for too long. We need to release. So that's why when you get sick, you are alternating pale and shaky with sweaty, because your body is doing what it's supposed to be doing. It's like, I want to be now, instead of 98, I want to be 101. That's where we're going for. So it will ramp you up to 101. It's like an oven where it clicks on and clicks off, or your heater, it clicks on and clicks off to keep a certain temperature. The brain has just decided that you have a new temperature, and that's what you're getting. Well, this annoys us. So we say, no, we don't want that. So you take your Tylenol, and the Tylenol shuts down your brain signal to keep a higher temperature. So when you take Tylenol, all you're doing is telling the brain, no, we're not, the brain's still like, hey guys, 101, I told you 101. And the body's like, we're not really listening to that. When you take Tylenol, you shut down the response to those signals and those mediators and things like that. So basically we're not allowing this process to happen. So we don't have a fever because the body's not doing this thing. And you don't need to do this because you don't need to cool down from the heat raising source. So when you take Tylenol, you're just like, no, we're not going to listen to that. The brain's like, dude, I said 101. And the body's like, nah, we're not, no. Tylenol told us not to. So we're not going to do it. So anyway, this is where those things work. The headache and pain is from those prostaglandins that the brain is releasing to get all this going, and you end up being more sensitized to pain. So when you take your Tylenol to get rid of your headache from your fever, you're basically just blocking the fever. And that's fine. We feel better, but the brain was sending out a signal for 101 for a reason. You have an infection of some kind. So it just takes longer for the infection to go away because we can't cook it. We'll have to wait for our immune system.
No, I'm just answering.
Oh, okay.
You said it takes longer.
It takes longer. So that's why, my kids are like, I want some Motrin. I'm like, no, you're going to suffer. You're going to suffer. One, because when you're malaise, you don't bother me. So, yeah, we like you suffering because you're over there shivering and sweating, but you're not bothering me because you're tired. So leave me alone. So you're going to keep your fever. So if we had fever, so what I would say is your first SOAPy card should be for fever, probably, if you want a SOAPy card for fever. Because what are your signs and symptoms of fever are all the things we just talked about, okay? The pathophysiology behind them, cook bacteria. That's what we're doing it for, okay? That's the only reason, that's the only background you need off of that. Is it a priority? Is this a priority? Airway, breathing, circulation? No, not really. It's not a priority at this point. In general, fever is not a priority. When would fever become a priority? When this other process doesn't work and your fever keeps climbing and climbing and climbing. It overshoots. And now you're up at 105. Oh, that's a problem. That becomes a priority because now you're cooking your brain cells and stuff like that. So then it would become a priority. Normally, not a priority. But if you wanted to put in your A section, a priority if fever goes above, sustained fever over a long amount of time. That's why they're always like, look, if you put your kid in the bath or you get your fever down, then we don't mind. But if you can't get the fever down, you give Tylenol and it doesn't work. And it keeps rising. We have a problem. We're not regulating properly and that needs intervention. So, but normal regulation is normal. So, our plan in this little P section here. What is your priority? What are you, so we're going to skip. So see how our lectures were not really fully what you needed. So I'm working on that. I'm working on changing them out. So not an airway, breathing, circulation problem, only a big problem, priority problem if your fever is unattended. But what would be your nursing diagnosis that goes with this? What would be your priority nursing diagnosis? Not just any.
I would think like fluid, dealing with their intake and output because they are sweating and they need to keep their fluids and electrolytes.
Correct.
in
So
check.
fluid and fever go together. Why? Because of this. One, if you don't have enough fluid, this doesn't make any difference. Okay, if you don't have any fluid, the clamping and the releasing don't change anything. If you've sweated everything off, then you can't cool. The same way you end up in a heat stroke. If you don't have enough fluid, you can't cool, so you can't regulate. So yes, you need to maintain your fluid status. So I would say definitely with a plan, especially to allow the fever to do what it's supposed to do, you need to maintain your fluids. So maintaining fluid status, but watching for dehydration. That's probably, so let's talk about what's the worst thing that could happen with your fever. Yeah, it goes too high.
Have a
Okay.
seizure.
Right. Seizures, goes too high, have a seizure. So what do we do? And that's where, so when we're looking at that card, we were looking, okay, what's our worst possible problem? What do we do to keep that problem from happening?
You regulate it with antipyretics around the clock. If
So
you go too high.
you can do that. Fluids are first. Fluids are the best because going out of control and cooking yourself is because this can't work, right? So if we give ourselves fluids or make sure that your fluid status stays good, you shouldn't end up cooking yourself because we'll be able to diaphrese and cool ourselves. So we'll give fluids first. If the fluids, or if it's sustained, really high, we'll do antipyretics. So yes, so basically to keep the worst case scenario from happening, which is where we're talking about plans and goals, we want, what's our worst thing that can happen is the fever going out of control and you're having seizures. Why are you having seizures? Your brain is cooking. We don't want our brain to cook. It's not good. So we want the fever not to go out of control and we want to not have seizures. The way we do that is to keep our fluid balance in line and to give antipyretics. So that's our priorities, are to keep the fluid from getting out of control. If the fever's not out of control, leave it alone. You don't have to treat it. It's only if the symptoms are very, very uncomfortable to the patient or your fever is going out of control that you have to treat it. So those are your priorities. So let's talk about our interventions. These are the things. So we're going to definitely keep an eye on that. And what other things you need to keep an eye on to make sure that doesn't happen, or how you know that's happening?
Vital signs.
Temperature. Yeah. What vital? When you say vital signs, I'm always going to ask you which one. Temperature's the vital sign I really want. There's one more vital sign.
Blood pressure.
The blood pressure. Why the blood pressure?
Because it's the vasoconstriction and dilation is going to be.
It's going to change your blood pressure. Your blood pressure may be changeable, but if you're dehydrated, your blood pressure is going to go really, really, really low when it does this, and it may not go very high. You may end up with a lower blood pressure. So part of those priority assessments are your vital signs, because your blood pressure could be changeable, your heart rate could be changeable because your heart's trying to bump it up. So basically all of them, but the most important vital signs I want to make sure you get is your temperature and your blood pressure. So those would be, so that's in your priorities. So we're kind of going into the interventions here. We're moving away from the priorities and we're just talking about taking care of it. Same things. What are you monitoring, assessing? All your vital signs. Your blood pressure, your temperature, also your heart rate and your respirations, because we know with a fever, those are going to go up. So are you going to freak out when their blood pressure is 100 over 80, and then their heart rate is 100, and their respiratory rate is 24? And they have a fever. Do we intervene on those things? No, but it's good information. The body is doing what it's supposed to be doing. I'm going to keep an eye on that, because if it stops doing what it's supposed to be doing and things go out of control, I do have to intervene even more. So we're going to monitor all of that. What else would we monitor?
I know.
Definitely. Your fluid intake. Are you drinking enough? Are you peeing? RP is the best way to tell if we're drinking enough. You know that. If you don't pee for 6 hours, you probably aren't drinking enough. If you don't pee for 8 hours, you're not drinking enough. So yes, definitely I's and O's means, it doesn't mean you have to write the number down in the chart at the end of the shift. Are you eating enough? Are you peeing? Are you drinking enough? Are you peeing enough? But yes, monitor their I's and O's. What else? Do we want to monitor anything else with fever?
Maybe their level of consciousness and
Possibly. Hopefully, if everything's within control, their level of consciousness shouldn't be changing too much. That would be something that we would see if, things are out of control. If you're monitoring what you're supposed to be monitoring, you're not going to come in and find your patient seizing because you're monitoring what you're supposed to be monitoring. So what are we going to do? What are we going to perform? Here are the actual meat of our interventions. Well, we don't want things getting worse. We want hand hygiene. So the things that say monitor, you put those under monitor, assess, and then there's the perform, which we are going to do. You're going to do your hand hygiene. You're going to increase your oral liquid intake because we want to make sure that they stay fluid filled. We're going to give them food. Have you ever heard feed a fever? Feed a fever, start a cold, whatever it's supposed to be. But anyway, feed a fever is because your metabolism is ramped up. That high fever, we got to maintain that. There's a lot of work to do to mount a fever. You got to have a lot of little muscle shivering and a lot of metabolism going on. So you get a high, you need more food when you are mounting a fever. That's work for the body. So they need food. Administer antipyretics. So where I had monitor, those are the first things, monitor, assess. So temperature, blood pressure, skin color, and temperature. That's going to tell you, you can look at someone right there and you know exactly if they're spiking a fever. If you go pale in front of me and you were talking about, you're like, oh, I feel pale and not feeling sick. I'm feeling sick and, I bet your temperature's going up. And I bet if you took a temperature, you would see it. But you could see it before it happens. Or someone's now had fever, you gave them Tylenol, and now they're sweaty. Oh, hey, guess what? You're probably cooling down. I bet your temperature's going down. You can see this stuff. It's just extra information. I mean, you know this stuff. You know more than you think you know. So what are we going to teach a patient? So that's where our slides are weak, and I realize this. We are pretty weak in teaching you the whole process. So I will be building and changing slides based on this as well. So this is the other performance. We're going to do antipyretics. I think we put that on at the bottom there, antipyretics. If you want a drug card off of that or put those off to the side, you're going to write antipyretics. That's a class of drugs. What are the most common ones? There they are. Tylenol, aspirin, ibuprofen, naproxen. We're not supposed to teach you brand names. No hospitals use brand names. They only use generics. So the generic for aspirin is aspirin. It's just itself, but it's called a solicitate. It's kind of the kind of drug it is. Acetaminophen is on its own. Acetaminophen is Tylenol. It's just on its own. It's just Tylenol. It is what it is, but it doesn't have any other kinds. There aren't any other kinds of Tylenol. I think in Europe they call it something else. What do they call it in Europe? My daughter was telling me she went to Germany and she was like, "Where's Tylenol?" I'm like, because it's not Tylenol. It's something else in Europe. I don't know what it's called. Non-steroidal anti-inflammatories are kind, and those are ibuprofen, naproxen, Aleve, all those other drugs that are out there it's a non-steroidal anti-inflammatory. So those are the three, aspirin, Tylenol, and the non-steroidal anti-inflammatories are what you're going to need to know for antipyretics. So what would you teach? What would you teach if you have to teach your patient or teach families about their fever? What would you teach them?
fluids, just encourage fluids.
Fluids.
Monitor.
Let it run.
Keep an eye on it. Let it run. Tell them why you want it. Tell them what you just learned. That's the thing. The more you know about something, the more you can teach. Okay? But you'll just teach them about fever. The other thing we always want to teach is, okay, this person's sick, they got a fever. Maybe the rest of you should be washing your hands, covering your mouth. Let's not make the infection any worse. We already got an infection. This person's already working hard to maintain this. Let's not add any more germs to it. What would you do to, what was manage about? I'm trying to remember what was in Soapy Card.
Collaborative team member.
Oh, yeah, do we need to pull any team member? Thank you. This, do we need to pull any other team members into this? Does this require a lot of resources? No, there isn't anybody else. We don't need to manage or refer anything for this. And what do you think your patient's feeling like? They feel like crap. Maybe this isn't the best time to do a whole new teaching process. Maybe this isn't the best time to, try to get discharge teaching done, or, whatever. Just those sorts of considerations. And then how do we evaluate it? Well, hopefully their temperature stays below the danger zone. Usually we call the danger zone right around 102. Most people, you call a doctor, they don't care unless it's over 102. Because over 102 is where you start having problems with, causing damage to your organ tissues. They'll maintain 102 for a while, but we usually over 102, 38.5 is like the golden numbers in medicine. Your book may say something different, but usually in medicine, when they write orders, they'll say notify if temperature above 38.5 for that reason. And we're going a little slow through all this stuff because I'm trying to introduce the SOAPy concept. So that's the kind of the evaluation. So let's see. Let me just flip through this really quick, and then we'll go on a break. This is a drug class that I just want to bring off to the side. So this is not a disease process. It's a drug class. I think, if you have a card for your antipyretics, then I would say have a drug card for anti-infectives as well. But you're not going to be able to write every single antibiotic. There are billions of antibiotics. What you're going to want to know is just kind of some vocabulary around anti-infectives. There are narrow spectrum, there are broad spectrums, and the different classes of antipyretics. Like, there are penicillins, there are cephalosporins, there are a bunch of different kinds. I'm not going to test you on antipyretics, but what you're going to need to know is that an antipyretic is going to be an intervention for an infection. But this is just some information that this is the best place to put it. Anti-infectives, this is what they do. Anti-infectives, you don't choose them. You're not an NP. You're not a doc. You don't choose them. You just administer them. But we want to make sure that, here's how they choose them. PO versus IV is how bad the infection is. The patient's ability to eliminate the drug. That's how they choose them. You don't have to memorize this, but you have to know that this is usually one of our big things with anti-infectives, with antibiotics, with antivirals and things like that, is if their liver and kidneys don't work, we don't want to give them too much of it. They become toxic. And then, other factors. So for you and anti-infectives, what do you think your nursing concerns are going to be around this? Around giving an antibiotic?
Well, if they are, normally it's a BID or TID or even
Correct.
QID, so it would be like, are they going to take it on a regular regimen and finish the 10 days? Or would it be better to give them an IM or an IV and keep them in a hospital to fulfill that?
So those are not your decisions, though. That's the thing, is like, which ones are your decisions, which ones are not yours?
Allergies on time.
Yeah, your decisions are going to be making sure, one, teaching them all of this, yes. That's not your decision to do, but you could explain to them why these decisions were made. The other thing is, yes, allergies, big one. We need to make sure these are very reactive kind of medicines, because what we're doing is we're dealing with medicines that are helping or the immune system. So the immune system gets really kind of sensitive about these. They're trying to come in and do our job, and they get really antsy, and so the immune system gets really worked up by these, and they're very high allergen medicines. So check for allergies. The other thing that, and all the things that you're going to do with an infection, which is all the things, and that's teaching. I don't have teaching on there. My slides have been weak all along, and that's one of the things that we kind of miss sight of, that we do a lot, and I think because we do it so much, it's second nature, but we do teach about it. But the things that you need to know, if you see an antibiotic on your patient's chart, is that they need to be on a schedule, okay? These things work by maintaining a certain level in the system, so you need to make sure they're on a good schedule. That if you give IV fluids, especially IV antibiotics, just make sure sensitivity reactions don't happen. This is a big one that I don't think was ever talked about. I realized this when we were in clinical, that it never got discussed anywhere, so I put it here. If you're going to culture something, you need to do it before you give an antibiotic. So if you want to know what's growing, don't give an antibiotic and then collect a culture, because it will affect the culture results. So if you have a sputum culture to get and an antibiotic order, which one do you do first? The sputum culture. Thank you. Believe me, you're like, oh, who wouldn't know that? ICU nurses that I've been working with for a long time. So that's one of my joys of being a charge nurse in the ICU, is I watched a lot of nurses do a lot of things, and you will find out I have trust issues. So I'm like, So, I'm like, what can I do for you? What can I help you? And I'm like, they're like, oh, I have an antibiotic due and I need to get a sputum culture. Can you go hang the antibiotic? And then I'll try to get a suction thing. I'm like, wait a minute. Get the culture first and then I'll go get the antibiotic. Because why would you get a culture after you give an antibiotic? We just killed off all the germs that we were trying to grow. So always do cultures and sensitivities before giving your antibiotic, if you can. And you can give antibiotics before the results are obtained. You just got to get that culture out of the person and to the lab before you start giving antibiotics. And then, of course, assess them and make sure that things are getting better. You're going to keep an eye on their labs because if it's affecting your other organs, you're going to want to make sure that, your kidneys and your liver are staying healthy. You're going to make sure that it's actually working. How do we know that an antibiotic is working?
If you culture again, then
So that's going to take a while. Cultures take 3 days to grow. So how would you know that an antibiotic is working before you get a repeat culture? How would you know? Your fever infection response goes down. What else is going to go down? Your white blood cells will go down. Okay? Because they're not as needed, hopefully. Unless there's a whole bunch of other. See, everybody wants black and white answers from me, and I'm going to be like, you're not going to get black and white answers because there's always a patient that messes with your black and white. So, yeah, usually your white blood cell count goes down unless they have chemotherapy or they've got some kind of problems or they're autoimmune. Then their white blood cell, who knows what it's going to do. But usually the white blood cell goes down. So that's what we monitor, is we're going to monitor our fever, our blood pressure, our respiration, see the fever response go down, and we're going to watch our lab work to watch our white blood cells go down, and we're going to make sure that our liver and kidneys don't have a problem. We're going to make sure those don't go up. So that's with anti-infectives. Here's the oh, look, I did do it. Yay for me. There is teaching involved with make sure they take the full thing. So there is teaching involved with those as well. So if you do a drug card, what I would say, I haven't developed a template for a drug card. If you do it, just do classes. Know the most common drugs in each class, because NCLEX will pull out, they'll say acetaminophen, or they'll say, a cyclosporin, or they're getting a penicillin, or they'll pull out maybe a common med or two. I would say probably the most common meds. Don't write down every single med in your drug book because there's probably 1,800 under anti-infectives. Just do the classes. Yeah.
Why do antibiotics affect like other medicines that you take, such as like birth control and stuff like that, where they say that it's not as effective if you're on an antibiotic?
I don't know. I'd have to look that one up. I don't know. I don't know. There's probably a very good reason, but I don't know it. So, what's that?
Is the way to begin prescribing antibiotics is how less of an effect it has on the body compared to like how if you keep going further down, it's more.
The antibiotics are prescribed based on the best antibiotic for the bacteria that they think they have. So if you have a pneumonia, the doctors and NPs know the most common bacteria that cause that pneumonia, or that cause pneumonia, and they use a broad spectrum. And when the results come back for the culture, it will tell you whether that antibiotic works for that med. So I don't know if you've ever had a UTI and you send off your urine, and they say we're going to call you in a couple of days to let you know if we need to change your antibiotic. That's why, because they said, well, we know that urinary tract infections are caused by usually these top 3 offenders causing urinary tract. So they give you a med that will kill those 3. And then if something grows in the culture that they're like, oh, you didn't have one, you had a weird one, we might need to change your antibiotics a little bit. So that's kind of in there. But yeah, these broad spectrum antibiotics kill a lot of stuff. They also kill your gut bacteria. You would start with broad spectrum, and then they can change, or they can say, all right, just stay on that. Or if you've had it a lot, maybe they say, or you're having GI problems, they'll change it to a narrower spectrum because now they know what the drug is. And then alcohol, yeah. And I'll see if I can find the answer about the other medications.
I just found out. So with the birth control
Google.
pills, they contain estrogen, obviously. So some antibiotics, right, they cause the enzymes in the liver to increase the breakdown of the estrogens.
Oh, okay. Well, there you go. So, yeah, I thought it might have something to do with elimination or the liver, the kidneys, but I wasn't sure.
Do fevers kill your gut bacteria?
What's that? Do fevers kill good bacteria? Yes, they do.
Your gut bacteria.
Do they kill your gut bacteria? Your gut bacteria are very resilient bacteria. They're used to living in acidic environments, and they are not as affected, but it can. Yeah, fevers can kill your good bacteria as well, because that's what we could kill our body cells. Yeah, so it could. But it doesn't do it in the large numbers that these broad spectrums do. They're out there because really these antibiotics are in addition to your immune system. So your immune system's killing things, and now we've got antibiotics going out there and directively, damaging bacteria as well. So we're double duty. So our natural body fever wouldn't kill as many gut bacteria, but then when you throw an antibiotic on top of it, it doubles the amount of bacteria that are dying. Yes?
Why do you avoid antibiotics that decrease absorption?
Yeah, it decreases the absorption, especially with POs. And so does alcohol. And alcohol will mess up your liver. So, your liver doesn't do what it's supposed to be doing, and it doesn't, denature things. And you've got antibiotic running around, and then you've got a level growing higher and higher and higher because you're drinking at the same time. Yeah. And let them know about allergies. This is just an information slide, and these things are usually the hospital acquired, not H1N1, SARS, Ebola, but you'll see C. diff, MRSA, VRE, strep pneumonia. These things are usually only found hospital acquired. They're not just out there in the community, but these are the biggest problems. I got this from the CDC. These are the biggest problems. And you went through all standard precautions, contact precautions, all those different precautions, right? A lot of times I can't even keep straight which ones go with which precautions. There is usually a policy at your hospital, or you go to the CDC and it'll tell you, for this infection, do these precautions. So if you're ever confused which one you're supposed to use with which thing, you can go to the CDC. So we're going to do this. We're going to take a break. Can you all read it? This is the fun part. You get a whole bunch of information and you got to find stuff. That's what our test questions are like. You're on information overload and you have to answer questions. So what's your priority? So let's see, this is where I'm going to start scribbling on the slide. What word, so if you could pick 3 words that concern you out of this whole story, which 3 words concern you the most? Oh, thank you for finding that word. Cellulitis. Okay, that's a big concerning word. What if you could pick 2 or 3 other words? Or vital signs. Pick 2 or 3, anything off of this write-up that worries you. Temperature, and you want to pick heart rate? Anybody want to pick anything else?
Because they have a history
We'll put
of
a push.
hypertension. That's pretty low.
Oh, true. Good pickup. That's my blood pressure. Well, not the 48 part. My blood pressure is like 108/64. That's my blood pressure. Wouldn't bother me. I'd be like, hey, I'm okay with it. I'm going to also tell you one more, and we kind of talk about this in you know what, I'm going to save it for the cardiac lecture. I'm not going to. Okay. Cellulitis, heart rate, temperature, those are considered. So the reason, we kind of draw a link between this. All right, if they have hypertension, so they could either be a well-controlled hypertensive, or there's something wrong. So I'm going to put that as a question mark, but I do like that tie. What else? Anything?
If they have cellulitis, they're going to have potentially poor circulation.
Okay, so I didn't mean to cross it out. I meant to underline it. So this is where we can start. This is where I want you to start thinking priorities. So when you have a patient like this, you can go off in 800 different directions and come up with 8 billion different nursing diagnoses. Oh yeah, diabetes, cellulitis, whatever. So diabetes causing cellulitis, is that a pressing problem or a long-term problem? Long-term. So let's just move it aside. So we're going to kind of think priorities. Yes, it is a definite consideration, but it's not a priority consideration. So we're going to underline are stuff that's probably not a priority. I'm going to circle my priorities. I'm going to underline things that I want to address. Vital signs, this is not a priority order. Oxygen, okay. Airway always comes up as a priority for me. Do we need it? No. All right. So airway is not a problem. Airway and breathing are okay right now. Diabetic diet, okay. Well, they addressed that. Cefazolin, we got an antibiotic, up ad lib, tunnel. So what's my priorities for this patient?
Kidney, liver function,
So let's talk about what is our biggest problem that we need to fix right now. The infection. I'm not trying to trick you. Just trying to. Our biggest problem, our priority is the infection. Okay? Because if this infection goes out of control, what can happen? What's the worst thing that can happen to this patient if we don't treat the priority? It's already in the skin tissue. It could get into the bone. It could get into the bloodstream. Infections can run rampant. He's already being admitted for cellulitis. So this infection's pretty good, right? If it was a nothing infection, he wouldn't be admitted. He'd be going home on PO. So our problem is he's admitted for this infection. We need to make sure this gets under control before we start going down rabbit holes with other things. Okay? Our priority for this patient is the cellulitis, the infection. Now, we want to talk about the heart rate and temperature. Are those priorities that go with the infection, or are they separate? They go with the infection. So our interventions for our priority will fix these other problems that we're worried about, hopefully. So our priority for this patient is infection. What are our nursing diagnoses that go with the infection? So if we had an infection, SOPI, and we pulled it out, our priority problems are infection. And what went with the infection that we would worry about with the fever? Eyes and nose and fluids, okay? So my nursing diagnosis would be, there's a nursing diagnosis for hyperthermia, for fever. There's a nursing diagnosis for fever. I would say fluid. We want to make sure that he takes fluids. And, we want to make sure infections are a big diagnosis. We've got an infection going on. So what are our primary interventions that go with infection? What are we going to do? We want to prioritize this antibiotic. What else do we want to prioritize off of our order list?
Eyes and nose, fluids.
We want to make sure that they get their eyes and O's. We want to make sure maybe we start keeping track if we weren't before. And I want to do the vital signs, okay? Because the vital signs will tell us if we need the oxygen. Diabetic diet, up ad lib. Are we going to give him Tylenol just yet?
No.
I'm going to say not at this point. I mean, if the heart rate's not bothering him and he's not, we're going to kind of let that be. A lot of times it'll say Tylenol for temp of 101.5 or greater or whatever. But you have nursing judgment, or you will have nursing judgment. You know what a fever's for. If he's having a horrible headache, sure. But it's not your priority because it's kind of at this point, if his temperature's 102, I'd probably say, yeah, we're going to go ahead and keep it down below 102 because maybe he's overshooting. But right now, maybe he's just maintaining where we want him to be. So our priorities out of these order sets, I don't know what happened to it, would be getting the antibiotic in, making sure we maintain his vital signs. The rest of it can kind of wait. So it's kind of like those are our interventions. Could be anything, but I want you to kind of start thinking priority. Once you've taken care of the priority and you find yourself with more time on your hands, then you can deal with all the other things. Like, what if his diabetic diet wasn't ordered? You get that ordered. All these other things. Maybe do some teaching about cellulitis and diabetes. But you've got to get your priorities. You don't want to be doing teaching above giving that antibiotic because your priority is infection. So what are our goals for him? I would say that his, that his cellulitis starts to improve. The signs and symptoms of cellulitis improve. The white blood cells might drop. He gets his antibiotics on time. The cellulitis starts to get better. Long-term goals will be maybe that he verbalizes something about diabetes control and cellulitis and infection and things like that. But just for our priorities. Because sometimes it's hard to figure out, what do we do given all this information? So if you could only have time to do one thing, it would be hang the antibiotic. Okay? Because that will take care of all your other stuff. All right. Take a little break. So what I usually do in my classes is break somewhere around the 10 o'clock hour. We do a 10, 15-minute break. And then what I do is a 20, 30-minute lunch. And then we come back for the afternoon and have another break in the afternoon, and we get out around 2.
I like it.
Is that what you are okay with, or do you want a long lunch? Because some people probably didn't bring lunch planning on that, so.
Probably a long lunch, a lot of people go eat.
So if you want the long lunch, that's perfectly fine, because this is new, this is not your usual routine, and so if you didn't bring food because you want a longer lunch, we'll kind of call it even. So what we're going to do is we're going to take 15 minutes now, we'll see you back at 10:40. We'll go on and we'll do this part of it, and then we'll come back and do the cancer piece in the afternoon. We'll take a little longer lunch in between, so we'll probably go another hour, a little over an hour, and then we'll take probably a 45-minute lunch. Would that be fine? Do you usually get an hour? Oh, usually at 45 minutes. Can we take 30 or?
Let's do 30.
How about? We'll. You guys talk about it. We'll see what the reaction is when you get back. Talk about it on your break. We'll see you at 10:40. Question. This is very similar to what a test question would be. What is your priority? So which intervention would you do first? So if that was a test question, which one would you do first? The antibiotic would be the right answer. But then I would have people that would raise their hand and be like, they have a fever, I want to give them Tylenol. But the reason I'm giving you this background is so that you can prioritize your interventions, okay? Because the test question and NCLEX, so there's a big difference, and I'm going to kind of start teaching you, not teaching you to the test, but preparing you for this test. The NCLEX wants to pull out that you understand that the big problem here is infection, and that's what you want to treat. So when NCLEX is asking you a question, they're not asking you, what would you do? Hey, just give me what you would do. What NCLEX wants to know is, do you understand the importance of treating the infection? And so that's why the answer is the antibiotic. They don't want you doing a knee-jerk Tylenol temperature. So the answer is not Tylenol, your first intervention. Now, in the real world, would you give them both at the same time? If they were having a horrible headache, would you give them Tylenol first? Yes, you would, in the real world. But what NCLEX is testing you on, you have to think, when we are giving you a question on a test, what do we really want you to know? Do we want you to know to get Tylenol for temperature? That's kind of a very simple, basic thing. Why would we be testing you on that? We want you to know, when we asked you what your priority, what your first is, did you recognize the problem? The big problem is infection. That's why your priority is the antibiotic. So that's why in this situation, if that was an NCLEX question, the answer would be the antibiotic, not Tylenol. Even though in real life you may give Tylenol first. It's not asking you real life. It's asking you, did you identify the problem, and do you know how to stop that problem in its tracks so that it doesn't get worse? That's what a priority intervention is. So we will practice a lot more questions and things like that, but that's what we're aiming you for. Is when NCLEX is asking you a specific question, they want to know a specific thing about you. Do you understand something? And it's probably not, do you give Tylenol for a fever? All right. So, this is background. When you're talking about a hypersensitivity, meaning the immune system's gone a little haywire, they've got a little la-la. There are 4 kinds. You don't need to memorize each kind, but you will see that the interventions for type 1 and then some of our issues, the rheumatoid arthritis and stuff, are going to be type 3. That's just up there as a kind of a, when you see type 1, type 2, it's vocabulary. You know what that means, okay? So hypersensitivity allergy reaction, these are your signs and symptoms. So when you write your signs and symptoms, it could be any of these, okay? Any of these could go with any of these actions. A drug allergy can have itching in the nose, eyes, and mouth. I was painting my trailer, and I was washing my hands with that orange stuff because I couldn't get half of the stuff that I was using off. And so I used the orange stuff, that citrus cleaner, and I was trying to wash my hands just as a pre-rinse, and then I rinsed it off. Well, it turns out I was horribly allergic to that orange stuff. So not only did I got like one little rash here, but then I ended up with rashes on the backs of my knees, and I was itchy, watery eyes for a couple of days afterwards. It wasn't because I was allergic to something in the air. It was a dermatitis. But it actually showed up as so any of these can go anywhere. So don't just mark them for one section. Just know that hypersensitivity allergy reactions, you can even write on your little things. Think, what is an allergy? You know what an allergy looks like. Don't count yourself short. When we talk about diagnoses, these are things that you want to make sure kind of get implemented if you're at the beginning stages of this. Like if this is something that you don't know if it's an allergy or not, they may do some tests. Tests to find out whether you have a disease or not usually goes under the performance. Things you want to make sure happen if it's needed, okay? If the person says, I have allergies to, penicillins, then you don't give them a penicillin. You don't have to worry about performing skin tests, blood tests. Sometimes it's just the fact that these symptoms show up. But there are, if you want to know, you would put them in the implementation section. But this is how they do diagnose just type 1 sensitivities, if they're diagnosed at all besides symptoms, is they can do a skin test or a blood test. When we're talking about hypersensitivity, allergy, what do you think is our worst case scenario? What's the worst thing? Anaphylaxis is going to be our worst case. So that's what we're going to be watching for, is anaphylaxis. We'll talk a little bit more about that in a minute. This is just a little something about latex allergy. If they have latex allergy, it's not any different than any other allergy. You're going to avoid the contact with it. But the issue that we have is that the more allergies you have, or the more exposed to latex you are, the more prone you are to have a latex allergy. And most of our products in the hospital now are latex free, but there are some things that we haven't gotten the latex out of. Like I think they have mostly latex free Foleys now, and but we want to be cognizant of that because a lot of our patients have a lot of allergies. Have you gotten those patients that have an allergy list of like 10, 12 allergies? That person will be more prone to a latex allergy. They're already hypersensitive to a lot of things. It's very easy to get an allergy to latex. And then a lot of healthcare workers have it because they were exposed for so long, over so many times, that they now have a hypersensitivity reaction. So just latex allergy is pretty common in the medical area because we are dealing with sicker patients that have a lot of allergies and they're exposed to a lot of stuff. The sicker you are, the more you're in the hospital, the more you're exposed to latex, the more chance you have of it. So that is something that you'll see. And actually the other thing to know, and NCLEX loves it, latex similar foods. Have you seen those in any practice questions? If you have a latex allergy, they should avoid these foods. That's part of, that's like some interesting. If you wanted to do a separate card for latex allergy or something, if you wanted to put that teaching point in there. But that is something that they love to pull out of thin air. Do you know about latex similar foods? So I put it in there that bananas and avocados. I didn't know about all that. I don't know if those are considered. I don't know what there must be some protein in there that's similar to latex.
And potatoes seem pretty starchy.
Yeah.
Maybe there's
But tomatoes aren't. So I don't know. There must be something in a protein of those. But anyway, that's just something to kind of on the side. Just know that there are latex similar foods. So if you saw that in a question, they should not have those. So here we kind of go right into interventions here for allergies. Well, analysis, it's the immune system's kind of gone a little bonkers and gets a little over-exaggerated. So when the immune system gets over-exaggerated, what are they going to produce? What's it going to do? When the immune system gets it activated, what does it produce? It's going to produce histamines, it's going to produce swelling, redness, pain, kind of all over. It could be all over the body, it could be a redness irritation, it could be just localized at the eyes and the nose, it could be an irritation on the skin, could be anywhere. So that's kind of, the priorities and the plans are to keep them from getting to anaphylaxis. So we're going to monitor that this allergy isn't getting any worse. And what are our interventions here? What would we monitor and assess if your patient has an allergy and they're having an allergic reaction? You've seen the signs and symptoms. What are you going to continue to monitor? We're going to monitor the things that are going to keep us, to let us know if we're headed towards our worst case scenario. So you're going to monitor, of course, their skin and their allergy symptoms to see if they're getting worse. But you're going to monitor their airway. How do you monitor their airway? Oxygen, their lung sounds, their, listening to see if they're wheezing. So I would say lung sounds, oxygenation, that sort of thing is what you would monitor. If they've already shown up with an allergy, so when I washed my hands in orange spray and got rashes all over my body, did I ever develop to an airway problem? No. But I was certainly checking to see if the rash spread or stuff. So you're going to watch the allergy symptoms, see if they're getting worse. That's pretty much all you need to do to write down for what you're gonna monitor, assess. Perform, we're gonna do, so this is kind of out of order. This is all kind of out of order. So help us organize. Help us organize. Help you organize in your mind and help us organize. But what are we going to do for the patient with allergies? Teaching comes, we'll put that at the bottom. What are we going to do? We're going to give them antihistamines. Okay? Probably. Usually so your first performance, what you're going to do for that is you're going to stop the reaction. It's a hypersensitivity reaction. It doesn't need to happen. It's not causing anything good. It's just oversensitive. Not like the fever actually has a purpose. This is overdone. So we're going to probably give them antihistamines. Okay? Then you move off to a card to write antihistamines, and you can write side effects and all these little things on a card about antihistamines. Yay! The other, where in the world? Okay, I'm a mess. The other implementation, what we're going to do for allergies is possibly, if this is a long-term problem, one of the other interventions is they can have immunotherapy, which is allergy shots, which is a long-term thing where you keep producing the allergen until they create an immunity to it. The other thing they can do is sometimes steroids if the allergy is really bad, because steroids, what are steroids? Oh, we haven't talked about, we're going to talk about steroids a lot. They are anti-inflammatories. They do shut down the immune response, so it's pretty drastic, and we'll talk about steroids a little later on. But so for what we're going to do for these patients, besides monitor them, give them antihistamines, possibly talk to them about immunotherapy depending on what the allergy is, possibly steroids if the antihistamines, there's a whole bunch of possibles on there. But mostly, you're going to teach them. The biggest intervention for allergies is teaching. They need to know it's an allergy. They need to know to avoid it. I thought I wrote this on here. Maybe I put it at the end of anaphylaxis. Here. Nope. Okay. Wow. What a mess I am. All right, so what are we going to teach? What would you want to know about your allergies?
Stay away from
What you're allergic to, how stay away from it, to know that, what goes with those allergies. So you're allergic to the air, okay, don't go outside, But if you're allergic to latex, to avoid latex, there's a lot of teaching involved with allergies, okay? It's mostly teaching, and you're going to teach them about the worst case scenario. Here's what you know about anaphylaxis. You're going to know about anaphylaxis. You're going to teach them to avoid the allergen and to recognize signs and symptoms of anaphylaxis. I'm sorry I didn't write that out on a slide, but put that under your teach. Do we need to refer them to anybody?
Maybe an allergist.
Possibly to an allergist if they haven't seen anybody. If they have a long list of allergies and they just have a lot of allergies, you're going to make sure that they're maintaining, that they know about them. But you may want to see if they're seeing an allergist. So as far as getting other things involved, are you getting immunotherapy? Do you have an allergist? That sorts of things. You can just bring those questions up. It doesn't mean you have to do it. But you could start thinking about them long term. If they have a long list of allergies, are you seeing an allergist? You probably should. I think you need a specialist. And then if they're having an allergic reaction, they may be scared, worried, especially if it's something new. I mean, do they need, have you done all the teaching? Have you calmed their fears and all that stuff? So kind of, starting to think. I think the problem is when we presented stuff to you, we didn't present it to you in the right way. How would you know that their allergies were getting better? Or that you treated them appropriately with the antihistamine? Yeah. Do the signs and symptoms of their allergies get less? I mean, really, it's not rocket science. The thing that I do want to pull out for you is the antihistamines and the side effects, and know the typical antihistamines, know the side effects of the antihistamines and the teaching around it. So when we go off and I'm talking to you, okay, you need to make drugs around this. So, in their interventions, their implementations, you're going to give them antihistamines. And I say antihistamines, know the most common antihistamines, and know their side effects, and know the teaching around it. Hey, isn't that what you do in your med write-ups? You've probably already done them or whatever. But if you start kind of doing a classification, antihistamines, hey, if you have a patient that has an antihistamine, and you have all this in your phone or whatever, there's your med write-up. It's already done. The antihistamines, they all have the same med write-up. They all have the same side effects. They all have the same teaching. They all have the same monitoring implications that so just make it easy for yourself. So those are the most common antihistamines. You've probably heard of all of them. Yay. Okay. I had a patient once that told me they were allergic to Benadryl. Can you be allergic to Benadryl? No. Well, you cannot like the side effects of Benadryl. That's a lot of the teaching I do for people with allergies. Is it an allergy or is it an adverse reaction? Some people, and if you don't like the adverse reaction, people put it down as an allergy. So that's why they have us categorized sometimes in the hospital. Is it mild, moderate, severe? Is it a real allergy? Or is it you don't like it? I mean, I put down Cipro as an allergy for me because it makes me vomit nonstop. I don't like the side effect of it, but I'm not actually allergic to it. I mean, if it was going to save my life, I'd rather vomit. But that's the thing, is that a lot of people don't, and so the long list of allergies is just, so someone told me, oh, I'm allergic to Benadryl. And I'm like, okay, just humor me for a second. How are you allergic to Benadryl? I'm just curious. What signs and symptoms do you have? She goes, I get sleepy. Okay, noted, mild. You don't take it off of their allergy sheet, okay? If the patient is reporting it to you an allergy, it is for them an allergy, and when it's on the allergy sheet, it doesn't get prescribed to them. They don't like the side effects of it. Honor that, okay? So there is that, so I just smile and I say, okay, it's on your record, we won't give it to you, but I just want to educate you a little bit on the difference between allergies and, take it as you will. But a lot of times people put down, and if you've ever put it on your list as an allergy, and that's what we want to find out. Is this an allergy? Like, do you have a hypersensitivity reaction to it that could develop to anaphylaxis, or do you just not like the side effect? That's fine. We won't give it to you. I'm just curious. We shouldn't give it to you anyway. You don't like the side effects, so it's not going to cause anaphylaxis because we're not going to give it to you. But that's how people end up with a list of 800 allergies. They don't like the side effects. So let's talk about anaphylaxis. This is the worst case scenario for an allergy, is that it goes to anaphylaxis. Otherwise, we just kind of know to avoid it and watch it, and that's pretty much it. Give them an antihistamine. Anaphylaxis, the signs and symptoms of an anaphylaxis, is a quick response to an allergen, whatever it is. Could be a bee sting, could be a med, could be anything, whatever allergen. Seconds sometimes. Sometimes it could take up to 30 minutes to develop this reaction. But basically the immune system ramps up so hard and so fast that it creates these symptoms. And what do these symptoms do you think? Think about the immune reaction. What's happening here causing these symptoms?
Histamine.
Histamine is causing what? Inflammation. But what happens to the inflammation? You vasodilate and you have leaky capillaries. So you have fluid everywhere and you have leaky capillaries. When your capillaries leak, what are they leaking out? Blood cells, proteins, fluids, everything's leaking out. So imagine this happening throughout your body. Not just a capillary near where you've been injured, but all over your body. Your capillaries are leaky. You're going to lose your blood pressure. Okay? You are basically oozing all your fluids out of your bloodstream into your tissues. So, hey, look at that. So anaphylaxis sometimes happens systemically all over the body, sometimes localized in the head, neck area. But that's why you see so much swelling. It's an overactive immune response. So you get overactive swelling, overactive losing of fluid from your bloodstream. So you end up with a drop in blood pressure. The worst part of it is the loss of consciousness. Why do you get short of breath? Your airway swells up, okay? All this tissue swelling blocks your airway. Okay, all this tissue swelling around there ends up compressing your airway. So you end up with a drop in blood pressure, severe shortness of breath. You may have a rash. You'd be lightheaded and have a rapid weak pulse because you're vasodilating. Okay, you're losing fluid. So your body's trying we need fluid. Nausea and vomiting. Why do you nausea and vomit? Your body's, it's trying to get rid of it. You have something that your body is reacting to. It's going to get rid of it on every surface. So they may try to throw up on you as well because they're acting like it's a toxin. Severe angioedema. Angioedema just means swelling around the airway, okay, and around the face and the mouth. So if these are our signs and symptoms, what's causing it? Out of control inflammation. Is it an airway breathing circulation problem? Yes. Heck yeah, this one moves to the top of the soapy pile. I don't care if they have diabetes, renal failure, anything. This one's at the top of the pile. Why is it at the top of the pile? What's the worst case thing that can happen? You stop breathing, you stop having a blood pressure. This one is a priority, okay? So, what do we do to keep that worst case scenario from happening? Well, what are we going to monitor? Heck yeah, we are monitoring their airway, their oxygenation, their lung sounds, okay? We're going to monitor the amount of swelling, okay? Part of the airway, if there's swelling in the airway, we're going to hear, what are you going to hear? Stridor, wheezing, okay? There's also fluid leaking. Fluid might be leaking into your lungs. If fluid's leaking all around here, it might be leaking into your lungs too. If fluid's leaking into your lungs, what are you going to hear? Crackles, wheezing. You're going to hear a lot of lung sounds. So your assessment is focused in your airway, your breathing, and what's going to monitor your circulation? Blood pressure. So I want you monitoring if your patient is starting to swell here. They've had something they're allergic to. Now you start to see their lips swell and they're like, oh, I'm having a little trouble breathing. What are you going to keep monitoring? You are not going to monitor it once and stop. You are going to be constantly checking you might want to put them on an oxygen monitor. You're going to be checking their oxygenation, their lung sounds, their swelling. You're not going to leave this room, all right, until you're sure that this reaction is not getting worse. Yeah?
So if anaphylaxis occurs, do you call a rapid? Can you put an oxygen mask on?
So let's talk about our priority. Okay, so we know what we're monitoring, okay? So we've decided we're going to stay and monitor this patient. We don't like it. What else do we do? What are our perform? All right, well, here's a little slide so you can kind of tell the difference. These are signs and symptoms of your allergy, signs and symptoms of your anaphylaxis. Oh, there's so many different little slides. Let's talk about our priorities. This is what our priority is to do. Now, in the hospital, if they do not have an EpiPen, you will have to call for this. You can't just do it. Everybody wants their priority to be oxygen. I get that. I understand that. And yes, in the real world, we will do these things together. But what will stop the worst thing from happening? Why does Epi stop the worst thing from happening? So we're into the worst thing. We're in anaphylaxis. What's the worst thing that can happen from anaphylaxis? We stop breathing. We stop having a blood pressure, right? We need to intervene. Our priority intervention is Epi. Why? What does Epi do? Epi is our flight-fight response, okay? Epi is our adrenaline. Epi is that response. So what that response does when we have that, imagine that jolt of adrenaline. What does it do to you? It's going to up your heart rate, right? You can feel that. When you get a jolt of adrenaline, your heart rate starts going higher. It increases your heart rate, it increases your contraction, and it causes vasodilation because what we're doing is we are increasing our blood pressure. We're preparing for some kind of action. So what Epi does is it causes constriction of blood vessels, it increases your heart rate, and it relaxes the muscles around your airway because we're going to need to take in oxygen for this flight we're about to do. So it relaxes your airway so that you can get oxygen. Hey, aren't all those things that we want to happen to stop what's going on wrong? What's going on wrong is we are vasodilating and we're constricting our airways. We've got to stop that. We've got to get air. We've got to get a blood pressure. If we don't have a blood pressure and air, it doesn't matter what the rest of the stuff does, okay? Will oxygen fix our problem?
No.
It will support us. But to fix the problem, to stop it in its tracks, is Epi. And for anaphylaxis, the priority intervention is Epi.
Is that something we can get without a doctor order?
No. So that is something that as soon as you start seeing the swelling and the drop of blood pressure, that is a priority. You drop what you're doing and you call the rapid, like you said. In a hospital, you have resources around you. You're not the only one. You're not out in the field of the ball players and you're the only adults or whatever. You can call out. You stay with your patient and keep monitoring them to make sure things aren't getting worse, that we're not headed towards our disaster. And you know the priority intervention is epi. You can't get to it without the doctor, so you've got to get someone to call and prioritize this. And if you don't feel like waiting 20 minutes for your physician to call you back, you may need to get help to you rapidly, okay, depending on their blood pressure and their oxygen rate, but you're going to stay with your patient. This is not the patient to be like, sir, I'll be right back. I'm going to call the answering service. Hi, this is so-and-so with the patient. Yeah, we need to call back because my patient looks like they might be anaphylactic. Like, I called your doctor. This is probably not the situation that you want to do that. This might be somewhere where you need to grab help a little faster. Now, a patient that's had a reaction or has been educated about their allergies, maybe they know they have an allergic reaction and they carry an EpiPen. That's why they tell them, put the EpiPen in, do the EpiPen, and then call 911. Because what's going to happen after this EpiPen wears off? How long does Epi last? Not more than 30 minutes. And then you'll either need another dose or you'll need to be involved in the stopping this reaction. This will keep you alive until you can take care of the overactive immune system. It doesn't affect the immune system at all. It just gives you blood pressure and heart rate until you can get the reaction stopped. So our priority is epi. So if your patient is not immediately crashing, maybe they just have swelling and edema, and you're worried about things getting worse, you might have a little bit more time. Then your priority becomes stopping the reaction. But basically, what we're going to say for anaphylaxis is if your patient is anaphylactic, having trouble breathing, having a low blood pressure, get some epi on them. However you need to get it. Maybe they have it on them. Maybe you need to get an order for it. Maybe you need to get a rapid response team in. You need to get a doctor in your room right away. Do we need to give epi? And then they can assess from there, okay? Get help to your room. So you will perform epi if you have it, or you will go straight to manage. You need to get your referrals in the room quick. Yes, you need to refer this out. This is beyond your scope of practice. My patient is not breathing and whatever. So if you do not have access to epi, then you can go to your airway and ventilation, okay? The priority, if the question comes up, would be epi. But if epi is not available to you right away, then you go with what you got, okay? And do we do them both at the same time? Heck yeah, we put them all at the same time, for real. But the priority is epi because that will stop the worst case scenario from happening. The secondary treatment is what's going to actually stop this reaction. The secondary treatment is your antihistamines, okay? Benadryl. It will stop it will stop the reaction from getting worse. This will open up your airway. Fluids will treat the low blood pressure. And steroids, if you need them, will keep the reaction from coming back until that allergen has been removed from the system. So these are really also implementations. And maybe if your doc says, you know what, they're not bad enough to need epi at this point. Let's just go ahead and give Benadryl and a steroid and some fluids. But don't make that assessment on your own. Call. My patient is swelling around the mouth. I'm worried that their airway is going to close. Get some help. Don't try to manage it all yourself. Get your help. Go straight to manage, bring your resources in, and then they can decide. Because if they don't need epi, then they need to go to this thing. Oxygen is if they need it. Okay? If your airway is not swelling, maybe you're just really swollen on there, but your oxygen level is 95. Do you need to throw oxygen on them? It's all dependent. Okay? You will keep assessing. This is not a patient you leave. You stay with them. How will you know that your interventions were successful? What were your goals for this patient? Well, that's later. What are my immediate goals? How do I know that I'm safer to leave the room? Their oxygen's good, their airway is clear, their blood pressure is stable. Now I can leave the room and do other things. And then maybe assess, yes, as you're doing all this, their blood pressure stays stable. So you would say your goals for this patient are an oxygen saturation of greater than 92%. Lung sounds clear. No wheezing, no stridor, no crackles. My blood pressure remains above 100. I've got stable vital signs. And okay, those are my goals. Immediate goals. Long-term goals are that the swelling starts to decrease, and that they know their allergen, they can do it, So that's the kind of the evaluation of it. These would also be, these are all your things. So the priority is getting them epi, getting your resources. These are things that you're going to continue to monitor. These are actual interventions that will help you get, support. The things that will support them and start to make it better. So you've dealt with getting the worst case scenario. And if they're starting to get better, then you want to support their blood pressure with fluids. You want to keep monitoring. Most of this is monitor. Hey, here's down here under care. They're scared. They can't breathe. So here's care. So we're going to start thing. And then for long-term care, long-term management, if they've had an anaphylactic reaction, they're going to go home with an EpiPen. They're going to get an order for it. You're going to have to teach them how to give an EpiPen and all that stuff. So, yeah.
So after the EpiPen, after the 30 minutes, then
They need to be at a hospital.
what would we do? I mean, in that case, if we were the ones.
Hopefully you've started all your secondary stuff.
Okay.
Hopefully you have orders for this stuff because this will keep the reaction from coming back.
Oh.
Okay? This is what we need to do. You know the background of allergies. You know that Epi is just going to support you, but the allergic reaction is still continuing. Right? And as soon as you stop that Epi, you're going to fall out again. You've got to stop the allergic reaction. So these are what's going to stop it and keep it stopped. So let's say you had, I think there's a whole, let's see if there's a
There's a case study.
There's a case study. Let's do it. Oh, sorry. My thing's freezing up. Okay, stay there. So there's a lot to read, and I'm only going to want you to circle 3 things. All right. I definitely want to circle that. I probably don't want to go any further, but we're going to circle that. All right, we're going to circle, everybody agree? We're going to circle wheezing. Where's that? Oh, it's on there twice. Okay, we could circle that twice because that's it. What else are you going to circle that's...
Respiration. Yeah, respiration rate.
Where's our respiration rate? 39. I'm going to underline it because what I want is what's going to explain the wheezing and the blood pressure. I'm thinking that this is, so we have identified, I mean, you know what it is because we just went through it. But on a test, what would you identify here? What's the soapy card you want to pull for this patient? Anaphylaxis. I've identified this, okay? From this big, long thing, I've identified anaphylaxis. So this is the other thing I'm like, wait a minute. What is this? Doesn't anaphylaxis mean they have a swollen face? No. Not necessarily. Thank you. I just want to make sure that you understand. So some people will be like, well, it's not anaphylaxis because they weren't swollen. I'm like, that blood pressure gives you anaphylaxis. I'm sorry. Wheezing and no blood pressure gives you anaphylaxis. You may or may not see facial swelling. Okay? So, yes, you are still anaphylaxis even though that's there. So, wheezing, blood pressure. What are my priority? What is your priority for this patient? Well, yeah. That's my priority intervention. What is let's talk about ABC. Is my airway is compromised by wheezing, and my circulation is compromised by the blood pressure. Yes. My priority for this patient is stopping the anaphylactic reaction. Okay? 1, I need to support. Now, if his blood pressure was 100/80 with some wheezing, does that change your priority? I might not throw epi on this kid. I may move to my secondary priorities. But for right now, my blood pressure is low and I have airway compromise. My priority is probably going to be, if you had a list of interventions, so let's say we had a list of orders. The doctor gave you epi, stat, oxygen for sats greater than 92, a steroid, a fluid, an IV line. You know, you had a whole bunch of ER orders. What's the first order you do? The epi. Thank you. Because people will argue, well, I want to give fluids because look at the blood pressure. Yeah, I know. I get that. But we've got to get, I want the fluids. I agree with you. All of these interventions are appropriate. The doctor ordered all of them. What ones do you do first? Get the epi, okay? That will open your airway. It will give you vasoconstriction. It will help your blood pressure. As soon as you give the epi, yeah, you've got friends and helpers, you know, starting your IV line and doing other things and giving fluids and oxygen if you need it. You need it right now? We could throw oxygen on them, but unless we get that airway open, you can have 500% oxygen on them. Doesn't matter. So your priority is the epi if you had a list of orders, because that's the thing. Everybody's like, you always say airway and oxygen. I'm like, yeah, if it's appropriate. Come on, people. We want to treat the problem. The problem will be treated by epi. Then secondarily, what would I do next? What would you want to do next on this patient? So we give him epi. His blood pressure goes up to 100/80. He's still wheezing a little bit, but it's better. What do you do next? Yeah? Out of all the secondary interventions, what's the next one you want to do? The antihistamine, whatever's going to stop the immune reaction. Okay? Huh?
Do you need to get that out?
Oh, if it's in there, if it's still putting venom in, but the venom's already in the body and thing. I mean, that wouldn't be my priority. I'd get to that. But the thing is that we have done the immediate support. We've given the epi. The next thing we need to do is stop the immune reaction. Okay? I mean, whatever we're going to take to stop the immune, the only thing that's going to stop the immune reaction is the antihistamine or the steroid. Okay? Those are the two inflammatories that we
You have to
need.
think about it logically, right? Your epi only lasts 30 minutes.
Right. So
Continues.
the next thing you need to do is get in the antihistamine, so hopefully you don't need another dose of epi, because the antihistamine is what's going to stop the allergic reaction. Then you do all the supportive measures. Now, if your blood pressure, stays low and your oxygen starts to drop, then you continue to support that. And what we learned when we did trauma, is that you have ABC and you don't move out of ABC until you have solved those problems. I don't care what the rest of it is. You can manage and call resources to get go get my Benadryl, but you're still in ABC. You can't leave ABC. You're at a low blood pressure. If your oxygen level starts to drop, you're in ABC. You don't move out of that. You don't go get your Benadryl. Even though you know that will stop the reaction, you keep giving the epi. You've got to stay in ABC. You give epi, oxygen, and you stay in that mode, and you stay with your patient. Okay? When we talk about delegation and when you're in simulation, if your patient is having an ABC problem, do not leave your patient. Please do not leave your patient. Delegate to your PCTs, to your other friends, to your coworkers. You know you have friends in simulation. When you do simulate, we're going to do a lot of case-based simulation starting in block 3 and 4. And if you have a patient in anaphylaxis and you leave your room to go get your epi, I'm going to be like, are you kidding me? You left a patient that could be getting worse? Go ask some help. Grab your help. Delegate. So, you're always going to hear about delegation. That's where you would do it. If your patient is in airway, breathing, circulation, don't leave them. Stay there, because you're going to be the first one to notice if something's getting worse. And when you call a code, and they're going to say, what happened? And you don't want to say, well, I wasn't in the room. You stay with your patient. Stay with your patient and delegate out all the other stuff. You know they need Benadryl and they need epi. Go get it. You're going to give the epi first when it comes into the room. If their oxygenation drops, yes, oxygen. You need that. But if their oxygenation doesn't drop, you don't need it. So you give the epi, you see what happens. You're constantly reassessing. You're sending your friends and your delegates, hey, I have an order for Benadryl. I need to get Benadryl in this patient. I need to get the steroid in the patient. Could you please go get those for me? I'm going to stay and watch my patient. They can go get your Benadryl and your things, and then you get those in. But you are monitoring and staying with your patient. Those are the things I'm going to have you do, and I want you to know. Okay? With anaphylaxis, you're not just checking off a list. Your patient needs you. If your patient doesn't need you, so you give them epi and their wheezing goes away and the blood pressure comes up to 100, then I want you to know the problem's not solved. You got to get that Benadryl and steroid into your patient, and then you can start to breathe a sigh of relief and start looking at all the other stuff. But if your oxygen drops, you stay in EVC. You get the oxygen on them. Don't go get the Benadryl. Send someone else for it. So just kind of think like a nurse. All right, so we're going to you can read through slides, and you've seen the process that we're doing here. And if you have any questions, you can always bring me your Soapy card and say, did I miss something? Or send me an email and say, I'm having trouble identifying the priority here. I will help you. Send me emails, texts. I'm available. I'm in my office. So, lupus. Hey, this is not a type 1, it's a type 3. Type 3 is just like, this is a long term. You're with it for life. This just means that your immune system, it's an autoimmune disease, basically. It means your immune system's not working. You are going to have localized inflammation in random organ systems. Okay? We can't do anything about this. This is going to happen. This is the way the body's set up. It doesn't like something, and it will create localized inflammatory reactions. So for lupus, what are your signs and symptoms of lupus? How do you know your patient has lupus? How do you recognize it? Well, these are your signs and symptoms. They will have a butterfly rash. They have morning stiffness. Polyarthralgia just means it hurts all over. They got a lot of arthritis all over. They may have deposits in the lungs, so they may have trouble with their lungs. They may have tachypnea. These deposits get onto their heart valves and in their heart muscle, and so they may have problems with their heart. They may have seizures if these deposits are in their nerve tissue, and they may have problems with their kidneys. Okay, those are signs and symptoms of lupus. Lupus has periods of remission and exacerbation. So you may not see these symptoms if they're in remission. You only see them when they're in exacerbation. For the analysis of it, what's the background of it? What do we know about this disease? It's autoimmune, okay? Autoimmune. It's something that the immune system's kind of messed up. It's going to react wrongly to something. The thing that we need to know about the background is that these flare-ups are caused by these things, okay? So it's usually sitting around in remission, but some meds, viruses, which means illnesses, physical or emotional stress. So if you had lupus and you were in nursing school, you think you'd have a lot of flare-ups? Heck yeah. Every test you'd probably have a flare-up. Any trauma, so, you injure a bone or break a bone or any physical, emotional trauma, stress can cause a flare-up. So this means that any of these things cause the immune system to start depositing these local inflammation sites, okay? So it doesn't mean that you live with these symptoms all the time, but these 5 things. So someone living in Arizona going to nursing school with lupus probably is going to have a lot of flare-ups. Okay, they're in the sun. If you get sick and you're stressed, you're going to have flare-ups. So again, this is a sign. So we are more concerned not about the fact that you have lupus, but when we flare up. So imagine your patient has a history of lupus and they're in the hospital for a surgery. The chances of them having a flare-up are very high because that's one of the triggers, is any kind of stress. So here again, signs of butterfly rash. They'll get severely fatigued. They have pain. They have fevers. Why would they have fevers? It's a reaction. It's an inflammation. It's an inflammatory reaction. It's inappropriate, but it's still an inflammatory reaction. They do get mucous membrane ulcers in the mouth or nose. Why? I don't know all the pathophysiology behind it, but they do. So put it in your signs and symptoms. So if you see a patient presented to you on a test that has, maybe they don't say they have a history, they're in the hospital, they, got dehydrated, they had nausea, vomiting, they're throwing up, they have some kind of illness, but you note a butterfly rash and sores in the mouth, what do they have? Lupus. You've identified it. You need to be able to identify these problems because we don't tell you your patient comes in with lupus. We show you a whole bunch of stuff and you need to identify it. That's where these questions start getting complex. Raynaud's phenomenon. Have you seen that? That's where the fingers turn splashy. So those would all go in your signs and symptoms of lupus. That will help you identify that they have lupus. this kind of goes into the back of your mind. These are not typically signs and symptoms of flare-ups, but if they've had multiple flare-ups throughout their life, they start kind of, all these flare-ups accumulate, okay, and start causing problems. So if you're having a flare-up in your heart, what might you see? Murmurs, heartbeats. So the more flare-ups they've had, the more these symptoms start to show up. Okay, they're longer term. So an older patient with lupus who's had a lot of flare-ups, maybe they've never controlled their stress. Maybe in their 20s they went to nursing school and they've got a stressful job and and now they're in their 40s and having surgery. Their flare-up may look worse. Their flare-up may not just look like a butterfly rash and some pain. Maybe their flare-up looks like irregular heartbeats. Maybe they've got a cough and an infection in their lungs, because remember, those flare-ups happen in the lungs, the heart, the kidney. And the more often you have flare-ups, the worse your side effects are. So these are also side effects, signs and symptoms of lupus flare-up, but later, like if they've had a lot of flare-ups. So you wouldn't be looking for these things probably in a person who's just been diagnosed with lupus. Okay? If you've just been diagnosed with lupus, your flare-ups aren't going to be this bad, hopefully. But the more flare-ups you have, the worse they are. Why would you get blood clots? Those immune complexes. So they talked about all these little things getting deposited in the tissues, these little guys down here. They get deposited in the tissues, but they also are circulating around. It's just a big glob of immune junk, basically. And so those things cause blood clots as well. So these are all possibilities in your signs and symptoms of a flare-up, okay? These are things you want to be watching out for. So knowing all of this, what is your priority for these patients? So this is the treatment. This is just a little summary slide. So what is your priority for, why is this isn't moving on? Okay. What is your priority for this patient, knowing all of this? How can you identify one priority? This patient could be in a huge range of problems.
You would want to ask them about their lifestyle, like how maybe their lifestyle before they came to the doctor. And you can see if there's a stress in their life, maybe, and you can maybe narrow it.
Okay, so you have a patient that has signs and symptoms of lupus. You know it's an autoimmune disease. You know it has flare-ups triggered by all these things. So say, yes, you know that they have a stressful situation going on. You've seen some signs and symptoms of the butterfly rash. What is your worst case scenario with this patient? I'm going to say that these are my worst case scenarios, don't you think? These are probably the worst things that can happen with a lupus flare-up. So you could also put for your plan priorities, make sure that none of these worst case scenarios are happening. Make sure, check your heart, listen to their heart, see if there's anything new going on with their heart. Listen to their lung sounds. This is why their lung sounds are important in there. You're probably going to want your renal numbers. Okay? So when we're talking about plans priorities, and you know your worst case, even if you don't know much about this patient, you just know they have lupus, and you know they're in a flare-up because you see the rash and you've seen some things. Go ahead and do your priority assessments. Just make sure the worst case things aren't happening, okay? If they're not, great. If they are, you want to address them and recognize them. So here's the art of nursing. The more you know, the better you can take care of your patient. So the worst case scenarios are these. So I want you to listen to your patient's heart. Listen to your patient's lungs. Look at your patient's kidney values, and make sure everything's okay. If everything's okay, then you're not worried about your priority. What would you do to make sure that the worst case scenario doesn't happen? And we'll go to the implementation. What do we do to make sure that the worst case scenario doesn't happen? Well, the only way to control an autoimmune disease is to give them steroids. Okay? Anti-inflammatory medications and steroids are the mainstay for most autoimmune diseases. So you're going to see the words corticosteroids and steroids over and over and over again. It's the treatment for every autoimmune disease. We don't know why it's broken. It's broken. It's causing problems. Let's just shut it down. So that's what we do with these, is steroids and anti-inflammatories. Okay? That is going to be your biggest performance. You're going to monitor for the worst case scenarios. You're going to listen to their heart, listen to their lungs, watch their kidneys, and then make sure they get their steroids. Okay? We want to keep the flare-ups under control. The only way to do that is to shut the immune system down so that it's not flaring up. And then we prevent all that stuff. So clear your patient and then give them their meds. That's your interventions. What do we want to teach them? Well, obviously this is a long-term, lifelong disease, so there's going to be a lot of teaching. So administer the analgesics and the steroids. That should be your biggest perform, okay? Analgesics and steroids. What are you going to teach them? The listen and provide support goes under care. This is, you're caring about your patient. Teaching, you teach them about their triggers. This is where you talk to them about their life. You know, what's going on? Hey, did you know? Has anyone told you, you know, that lupus has flare-ups, and these flare-ups can cause these problems if you keep flaring up? So you need to stop the flare-ups. I mean, we can kind of tamper them down with steroids and stuff, but you're responsible for keeping your flare-ups under control, and you've got to keep all these things under control. Now, some of them are out of their control, but they can come in for earlier treatment if they know about it. Hey, I'm getting sick. I'm feeling a flare-up coming. I'm getting more tired. I might need some steroids. So, you know, you're going to be doing a lot of teaching in here. And do they need... this is the other thing they teach about oral hygiene, because it has those mucus sores and stuff like that. You know, so all these things are teaching pieces of it. And then do we need to send them off for what other resources may they need? This is a long-term illness. Support groups, make sure they have primary care physician, look and see if they have insurance. A lot of patients don't have insurance, don't take meds, don't have a full doctor visit. So when you're talking about managing, these are kind of discharge diagnoses sort of things, but let's make sure that you can manage this at home. And that's part of caring as well. So, yes?
Do steroid creams make fungal rashes worse?
Do steroid creams make fungal rashes worse? Yes, they can, because you're shutting down the immune system in that area. You're shutting down the immune response. So if there are fungus in the area, yeah, they can grow, because you've shut down.
Be careful with that.
It's risk versus benefit. When we give them medicines, there's always a risk to taking a medicine. So if they do have something, active infection in that area that you're going to give them a cream for, well, maybe not. Maybe that wouldn't be the best. That would be where you collaborate with your physician and your care team and see if that would be the best treatment for them. So that's basically quick, down and dirty lupus, okay? So you can start doing this with all of your things. Just start categorizing everything. So when you get a test question about lupus, you will know, okay, there is no, I mean, as long as their heart, lungs, and kidneys are okay, then we give them their steroids and teach them. Those are the priorities for that. And your intervention questions probably aren't going to be like, oh, what's your first thing to do? Because this is an emergency. But the questions are probably going to be around, how do you prevent flare-ups? What are the flare-up things? Because that is your core big problem with lupus, is teaching and having them understand this is a long-term illness, it's not going away. This is what you need to do. And so we want to make sure that you know to teach them that. Rheumatoid arthritis is the same kind of immune complex reaction, but instead of depositing so much all over the skin tissue and giving you a rash or whatever, they deposit in the joints. So this is the same thing, has exacerbation and remission. So guess what sends you to an exacerbation? Probably the same things, but we'll look. So you have pain, stiffness of the joints. The inflammation can also, so the way lupus went to the heart, the lungs, and the kidneys, where they like to deposit, rheumatoid arthritis likes to deposit in the eyes and the lungs as well as the joints. So in your signs and symptoms, you can write all that stuff there, and then those special little deposit areas that it likes. Over time and with enough flare-ups, it creates scar tissue in the joints, and your joints become immobile. Because this is an autoimmune with multiple flare-ups, the more you flare up, the more inflammation happens. Every time you have an inflammation, the scar tissue is like picking a scab. If you keep picking a scab, you end up with a scar, right? Same thing happens in here. It's constant inflammation, constant repair. You end up scarring, and then that area will develop tight, rigid scar tissue and bone tissue in there after enough flare-ups. So here are these other organ systems affected: skin, eyes, lungs, they do have some deposits in the heart and blood as well. So it's very similar to lupus, right? Rheumatoid arthritis and lupus have the same thing. It's just the different antigens causes different complexes to drop in different areas. So mostly the bones and the joints, but they do end up with these painless big nodules in the skin, that scar tissue in the skin under the surface. The eyes are a big one. So hey, guess what? Your patient's probably going to have itchy, red, painful eyes with rheumatoid arthritis, just as a nature of the illness. So with your priorities with rheumatoid arthritis, what are your priorities? What's the worst thing that can happen? Immobility, I think this is the worst thing that can happen. But in a flare-up, in an active flare-up, because the lungs and heart can be involved, I want you to at least put your heart, you listen to them, clear them. Okay, consider them, at least make sure that the flare-up's not affecting the lungs or the heart. Take a look at the eyes, see if they're itchy red. But the biggest problem for this patient is going to be the more flare-ups they have, the more immobile they are. And really the reason we're teaching you about these is because these patients do have flare-ups in the hospital, and we want you to know how to manage them. This is just for your own knowledge that it's hard to get a diagnosis of rheumatoid arthritis. It has to be, they have to have all this documentation that they have these rheumatoid lesions and stuff. It takes them like years to get diagnosed with rheumatoid arthritis. By then, most of the time, they don't get diagnosed until they start to have joint changes. They just know that they've had itchy, watery eyes. They've probably been told they have allergies. They have arthritis. They have allergies, but no one's actually done any workup on them to diagnose the rheumatoid arthritis. So this could be something that maybe you could make a difference in someone and say, hey, maybe, have you ever been worked up for rheumatoid arthritis? But there is also no cure for it, and we do the same medications, anti-inflammatories and steroids. Okay, so if they're having a flare-up, we will give them anti-inflammatories or steroids. This medication does have specific anti-rheumatic drugs, and those are the two anti-rheumatic drugs. So there might be something along the lines. And this, do you think this is a one-time dose or long-term doses? This would be long-term. So these meds, if they are on these DMARDs or these anti-rheumatic drugs, if you see a question about that, no, these are supposed to be something they should be on long-term. They knock down the immune system and prevent that immune complexes from forming. But yes.
When we talk about taking NSAIDs, are we still taking them long-term, even if they're a mild case?
They can. Some of them are on long-term, but the thing is that what's the problem with steroids? Have you just knowing just what you know from being out in the world? What's the big problem with steroids? It's got a lot of long-term side effects. We talk about them in Block 3. We have a whole big thing on steroids. Steroids cause increased blood sugar. They cause thinning of your tissues. They cause a lot of problems. So long-term steroids is not something that they like. What is the problem with non-steroidal anti-inflammatories?
GI bleeds.
GI bleeds and kidney problems. Okay, they have a lot of problems too. So we don't really want to put people on long-term forever and ever and ever, keep your immune system suppressed meds. So these are generally told to them now during flare-up times. You'll get steroids or anti-inflammatories. Not all the time, not daily. But the anti-rheumatic drugs are daily drugs.
Do you develop dependency as well? Or not dependency, I guess lack of effect?
Yeah, like they get immune to them. Yeah, with steroids, yeah, you'll need more and more doses. And yeah, with Motrin, I could tell you, I used to take 200 Motrin, now I take 800 Motrin. So the kidney doctor's like, make an appointment with me. Yeah.
So my uncle had RA and he's on chemotherapy.
Okay, well,
Is that
so I'm guessing that these didn't work. So what do you think? Well, we'll talk about chemotherapy in a minute. But that is a super immune suppressant. That is like the most immune suppressant that you can get. So they probably went through, all right, you flare-ups, you get these during flare-ups, but you don't get them long-term. Probably went through a couple of long-term meds that didn't change anything. The flare-ups kept happening, and so they're moving up in the ranks there. Do you think surgery will solve the problem? No, it's symptom relief. Okay. So in your interventions, what do we want to monitor, assess?
Heart, lungs.
I would like you to at least look at heart and lungs. just, for me, just to ward off evil spirits, get rid of the worst case scenario. But we are also gonna monitor, what are you gonna monitor then for them?
Mobility.
Pain, please, thank you, pain, mobility status, okay?
Do you have to also monitor their liver because of the medicines that they
Possibly, yeah, that would be a good thing. That's probably will come up when you look at the meds that they're on, that you'll have to look at the liver, but yes,
My friend has RA
So.
and she's had it since she's in her 20s and she always is getting,
liver checks.
for
Yeah.
her liver.
And it may be just that they're watching it to make sure it doesn't get up too high, too fast, or whatever. They might have damage to the liver if they're on some of these high-term meds. But yes, for you, I want you to monitor and assess, make sure their heart and lungs are clear, and then monitor their pain level is probably the biggest thing, because they're gonna have a lot of joint pain. What are you gonna do for this patient? Well, if it's a bad flare-up, they may get orders for steroids and non-steroidals. They may get corticosteroids, they may get non-steroidals. You would definitely give those. Pain control is going to be a big one for Perform. They're going to have a lot of pain control, increased mobility. So a lot of these are not, whoa, we got to take care of this right away. A lot of it's, how do I take care of a patient? You're going to see patients with rheumatoid who are in the middle of a flare-up, who are having other stresses going on. These are what interventions you're going to do to keep them comfortable and safe. Okay? What are you going to teach them? Well, make sure that they know about their, see what they know. See, they may be 100% adept at taking care of their disease. They're just in here for surgery and having a flare-up. But assess their, one of the things you can assess, do they know about their disease? Do they need any more teaching? Do you need to teach someone who's really good at taking care of their disease? Or do you need to start at the beginning and teach them you're going to adjust a teaching plan? If they're not taking care of their disease, they're non-compliant, you're going to have more teaching to do.
I'm not sure I remember reading this correctly, but with these diseases, you would have to watch for infection, right? So it's
If they're on an immune suppressant, yes, definitely, very good pickup. If they are on immune suppressant, rheumatoid arthritis itself does not predispose you to infection, but when we start giving you stuff to knock down your immune response, now you've become more chance of infection. Yes, that is a good point. But for this, if you're just talking about what you're implementing, most of your performances are going to be comfort measures. Teaching is going to be assessing what they need to know about their disease, whether they need to know anything about their meds. Do they need support? Yes, you're going to call in your occupational therapy, physical therapy. You're going to have them help you. They're going to need a lot of range of motion. You're not going to do all that. So a part of your manage is, yes, you're going to call in OT, PT. You're going to see if they have a support group. You're going to see if they have a primary care physician. But in the hospital, they're probably going to have physical therapy and occupational therapy involved with them as well. So that's that one. So you see, we can start speeding through things, right? You getting the idea? Okay. What will we know? How will we evaluate those? Sorry, before we leave, because I'm not good at the evaluation piece. How would we evaluate this patient that we've kept things under control?
Pain management.
Pain management, definitely. They're mostly joint comfort. So we want to make sure that their pain level is at a certain level. We want to make sure that their, ADLs, that they can move, that they can do things that they need to do. So scleroderma, I'm going to let you read through this one and do your own Oh, look, there's the steroid card. Hello, Miss Teresa.
Sorry to interrupt.
So we're going to let Miss Teresa talk. We're going to finish up the HCV and then we'll go to lunch. Okay?
You may want to just have him do this later.
Okay.
I have all your formative, summative forms that have not been signed by students. So we need